epinephrine gets control. And if you feel like you're losing control, if you're afraid you're going to lose control, if you can't even wrap your head around it because you're freaking out so hard, then go ahead and administer the epinephrine to the kid. And then that gives you time to think. We always talk about what happens if you don't give it, but when you do give it, it makes you feel better fast. And why make a kid sit there and feel totally miserable? Shut it down.
Welcome to the Don't Feed the Fear podcast, where we dive into the complex world of food allergy anxiety. I'm your host, Dr. Amanda Whitehouse, food allergy anxiety psychologist and food allergy mom. Whether you're dealing with allergies yourself or supporting someone who is, join us for an empathetic and informative journey toward food allergy calm and confidence. Welcome back for part 2 of this wonderful conversation with Dr. Michael Pistiner, pediatric allergist and director of food allergy advocacy, education, and prevention at Mass General for Children, Harvard Medical School. If you missed part 1 last week, go back and listen. We talked about the updated criteria for diagnosing anaphylaxis in infants and toddlers, what's changed, and what to look for during a reaction in very young children. In this episode, we're continuing that conversation with a practical focus on epinephrine, specifically which device is appropriate for infants and toddlers and how to administer it safely and effectively in such small children. Dr. Pistiner walks us through the technique step by step, shares tips for helping parents feel more confident, and explains how caregivers can prepare in advance. It's such a valuable conversation. I wanted you to have this right before the holidays, going into the time of the year where unfortunately we do experience reactions. Hopefully none of you will have a reaction at your holiday dinners, but if you do, let's stop it in early anaphylaxis rather than letting it progress further. For those who prefer visual learning, you will find Dr. Pistiner demonstrating this on video on my Instagram page at The Food Allergy Psychologist.
I would never call it mild anaphylaxis because that's an oxymoron. I'd call it early anaphylaxis, the perfect time to use epinephrine, because we're not interested in seeing what's going to happen. And as I mentioned it before, you don't need to wait for your 5 sneezes to turn into coughing, wheezing, respiratory distress. You don't need to wait until your local hives turn into full body hives with swelling, angioedema, and then a floppy kid who's having cardiovascular symptoms. Let's just treat them early on. As I was mentioning before, those mast cells and basophils, they get more stable when Epi is around, making it less likely for them to then keep going and then act kind of to trigger others.
I like people to hear it from you because you're the doctor, not me, but it won't be harmful to use the epinephrine, right? People are still afraid of it, and I want to keep dispelling that fear.
Yeah, so epinephrine is the medicine version of adrenaline. And so as I was mentioning, not only does it work on those allergy cells, but it also works on all the end organs that we want it to. And we always talk about the bad things that happen if you don't treat, but we don't really talk about the fact that it's going to make your kid feel better. If your kid is in the middle of an allergic reaction and they're barfing and they feel terrible and they're itching and they're getting cranky and irritable, make them feel better with the epinephrine. I think that one of the things that freaks people out is that it has traditionally been delivered through the intramuscular route, which people aren't used to. It happens to be safe. And for now, the intramuscular route is the only route available for kids under age 4 and under 15 kilos. And so there's intranasal epinephrine available for bigger, older kids. And then there are other modalities of epinephrine that look like they'll have FDA approval soon. But for now, intramuscular is what's available, and it works great.
And you brought demonstration tools.
I think so. Like, one of the things I like to teach parents is you guys need to teach the people who are going to take care of your kids. So you need to feel comfortable teaching others. And so that's tricky, and that's the challenge. One of the things that's going to help you in the perspective of anaphylaxis and epinephrine is going to be those action plans that we were talking about before. So getting one of those is going to be good. And then you'll want to get the trainer for whatever delivery system you have for your kid. So currently available, so the Teva generic epinephrine and the Mylan generic epinephrine come with trainers. The Kaleo AVQ comes with trainers. The Impax generic epinephrine does not. And so if you go to the pharmacy and you pick up your auto injectors for your kid and you don't have the trainer, then you could either call the company, ask for trainers, because you're going to need to train secondary care providers. You can't just wing it. And so for all of these, you could check out the companies to see their training videos, but then you also could check out the nonprofits, because all of the nonprofits are having different videos and ways to get comfortable training other people. So check them out, whoever you guys use.
Yes. And I will put links for that in the show notes too. And for those listening to the audio podcast, find me on Instagram at the Food Allergy Psychologist, and you'll be able to see the videos of this too, of Dr. Pistiner showing us.
And so, like, oftentimes when we use the trainers, we usually use them on ourselves, right? And so that's easy. But now imagine a little squirmy, wormy kid who's like really pissed, and then you are the uncle taking care of this kid and you don't even really know how to like hold him or anything. This is going to be what the parents, we are all up against, right? We got to get these like crazy Uncle Mike, we got to get him trained up. And so that's where you're going to want to use these trainers, but then also teach them how to hold and feel good about holding. I have some rescue mannequins. And so with the little kids, they're not going to be able to not take their hand and grab the auto injector when you take that short, skinny needle and you stick it in their muscle. Now, so first off, we're putting it in the lateral thigh, halfway between the knee and the hip, in the meaty part of the outer thigh muscle. Kind of hard just to say, but I'm going to show you. And so here, for a grown-up giving it to myself, I just took off the safety with my non-dominant hand. I'm holding this particular auto-injector in my dominant hand. I'm a righty. So now halfway between my knee and my hip, and I don't have a cell phone in here or anything, gentle pressure. I'm looking. Yes, it's a trainer. 1, 2, 3, and I got the dose. Now, the point, what I was saying before, is you're not coming straight in. You're not coming straight out from the side, but in that medius part of the thigh muscle.
And you said gentle pressure, not swing and stab, which is
I personally wouldn't want to swing and stab myself. But now think about a little Magoo. If a grown-up swings and jabs, they might miss. They might embed the needle and it might hurt. So just enough to actually trigger the needle is ultimately what you would do. And that's about 10 pounds of pressure. Now, let's say we have a toddler here and they're having an allergic reaction. In infants and toddlers, you can actually take their pants down. The reason you wouldn't necessarily think of it in a grown-up or in a big kid is because in public, dropping their pants could be a little embarrassing. And we don't want people to have to go and walk away and go into a bathroom. But in little kids, it's really easy to get access to that thigh. So drop their pants so you won't have the clothes to go through. And now I'm holding this auto injector in my right hand, my dominant hand. With my non-dominant hand, I take off the outer carrying case.
No needle or drug.
This one talks to me.
Purposes only. Do not use this trainer during an allergic emergency. If you are ready to use, pull that safety guard down and off of this trainer.
Non-dominant hand.
Place black end against outer thigh. Then push firmly until you hear a
So now let's pretend this kid doesn't really want me to be doing this, doesn't really know what's going on. And even if they let me, once the needle touches them, they may grab it. So now what I'm doing is I'm going to come across this child with my non-dominant armpit, my left armpit like a seatbelt. Now I have control of the thigh with my non-dominant hand, and now I can give the child their dose.
Training
The best they could do is punch me in the back of the head, and then I could give them hugs and kisses.
used for training purposes. Replace
Perfect. And so, yeah, then the
Ready?
child's arm that's on the side of the needle is kind of trapped underneath your ribs and in your armpit. You can hold the legs so that they're not kicking. Yeah.
So,
Very helpful.
yeah, so what we can do there is now I'm using my armpit across their waist, and their legs are right in front of me, and the kid would be facing behind me. Kind of like this. So then I'd have the thigh right there. Now, you don't need a surface. You can put the kid on the floor. They're not going to fall. And so everybody's got a floor. If there's two grown-ups together, then somebody can hold their hands and give them kisses while the other one has control of the thigh.
So helpful to see. Thank you so much for showing that. What else do you want to show visually?
Well, I mean, I just showed the rescue mannequin for a bigger kid, for the equivalent of a toddler, but the infant would be very similar. Now, the difference there, though, is that epinephrine is excellent to shut down an allergic reaction, but it only works if you give it, and it only works if you have it. And so there are different doses that can be used for young kids. And so where the AUVI-Q 0.1 is available, it's not available for everyone. There are some people who haven't had access to it. So what is available are the 0.15s from the other autoinjector companies. And so before the 0.1 dose was ever available, only the 0.15 was accessible. And so what the American Academy of Pediatrics, and then also what the practice parameters from the Allergy Society say, is that the 0.15 works. And if you don't have the 0.1, that's fine. Use the 0.15. Now, the additional guidance that I like to give is a slight adjustment, because the amount of epinephrine likely isn't going to cause significant side effects. The length of the needle might be something we can adjust for. And so in a small kid and their parents have the 0.15, I recommend bunching up the muscle away from the thigh bone, away from the femur. And so when you do the hold that I just talked about, then it gives the opportunity with the non-dominant hand to pull up the thigh muscle away from the femur, not going under the skin. So you don't want to go into the fat, which is subcutaneous. So you don't want to pinch the skin away from the muscle, but you want to bunch up the thigh muscle, and then you'd be able to then give that dose while the muscle's bunched up away from the thigh. Now, nobody's going to pick up their baby and do it in the air, but I'm just doing it for the camera here. 1, 2, 3.
And that's another misconception, because people used to think 10 seconds for the EpiPen and the generics.
Yeah, so initially, that's the way it was written. And then the Mylan generic and the Teva generic dropped the whole time. The Impax team didn't necessarily drop the whole time, and now it still says 10 seconds. But 10 seconds is likely way longer than we need, and a very, very long time to hold a child and keep them from moving with potential laceration. So when I recommend and have the conversation with families, I say hold for 5 if you can, and then if it starts getting tough, then pull out the needle. Now, what's different about the generic from Impax is that the needle will be out of the device without a needle end for protector even after it was administered. So that's what's a little different than the two generic epinephrine that are available. And the AUVI-Q, the needle is in the child for about 0.3 seconds. gives the medication itself retracts, decreasing the chance that somebody would then have a laceration. But they have a 2-second hold.
Thank you so much for explaining this. It's incredibly helpful. Is there other stuff that we didn't touch on that you want to add?
I mean, well, so one of the things that people are starting to hear about and should talk to their clinicians about, and if they have allergists, talk to their allergists, but the practice parameters, which is put out by what's called the Joint Task Force, which is the two American allergy societies and others have a work group that focuses on different things. And the 2023 Anaphylaxis Practice Parameter Update includes conversations that we can have with the families that we take care of that may make it so every time you use epinephrine, we're not telling you to call an ambulance, that we're not telling people to call 911. But now it's important to have shared decision making. It's important to talk to your clinician to decide if this is right for you and what circumstances you would consider this. And so what the practice parameters suggest that in this conversation that we talk about how you need to have 2 autoinjectors available first off if you're going to be thinking about this, because you need backup if the first one doesn't take care of business. One thing to know is that we were always, or when people hear people say, use epinephrine and call 911, it's not because the epinephrine's bad. It's because we're actually concerned that maybe the epinephrine isn't going to take care of it entirely. And then you might need IV fluid. You might need oxygen. You might need more epinephrine, and you might need more friends. And it's a nice, safe way to get to the ambulance instead of hauling ass while you're driving at 65 miles an hour with your kid in the back. And so those are the reasons why people have been saying call 911. But we now are saying that if you have 2 available doses, yes, it is anaphylaxis, but you only have mild symptoms and there's no severe symptom, if you are feeling like it is under control and that when it works, it almost entirely takes care of it, it doesn't progress and it goes away and doesn't come back, then you can then think about not calling 911, in which case then perhaps the allergists might have a triage line or your primary care team might have a triage line where you could call and then they could talk you through it. But of course, if there's any severe symptoms, if there's only 1 dose available, if it doesn't immediately go away, or if your child has other comorbidities or things to be thinking about, then calling 911 is a great idea because you got backup.
Thank you for clarifying that. I think I tell people this a lot. You still can, you just don't have to anymore, right?
Yeah, I still am getting comfortable with this. And so if I happen to be talking to a family after they treated their kid with epinephrine and it has completely gone away, I still feel a little angst and I'm still kind of like calling them back in 5 minutes and making sure that in fact the kid legit is doing better. That idea of the ambulance coming as backup in case something doesn't go as planned, that always has felt like a security blanket to me. But when you think about it, a lot of people have delayed shutting things down with their epi because they don't want to call an ambulance. And especially if your brain is going there, then just treat. And then you can have angst about whether or not you want to call an ambulance. But the sooner you treat that kid, the less likely you then will need to call the ambulance because of all the things I talked about before. If you shut it down before they lose all that fluid, if you shut it down before they have the smooth muscle constriction in their lungs and mucus plugging, then you're not going to need the oxygen or the IV fluid or more of the epi. There's going to be some kids who need a second dose, and that's why we say have the second dose. But the sheer majority, especially when early anaphylaxis is treated with epinephrine, the sheer majority only require the 1 dose, and it shuts it down.
Thank you. That's helpful. Dr. Stukas was on the team that did that, right?
I think he was on the work group for the practice parameter.
Okay. And so he did an episode on the podcast talking about this too. I'll link to that for people because this is still a hot button topic too. And I'm glad you included it here. Tell me if this is a bad idea or not. But a lot of people feel the same way you did and want some kind of a middle ground. So if all of the factors that you said are in place, if they've got the backup, the symptoms have subsided, all of those things. Another thing that's a lot of families, and I've done this with my son too, if there's another adult to stay with you and be in the car, we have just driven to the ER and sat in the parking lot for a little bit. Symptoms are gone, but someone's chatting with the kiddo and has eyes on him while we get ourselves close just in case, but we didn't have an ambulance and an ER bill in the meantime. I don't know what you think about that.
Being in a circumstance where then you can give your full attention to the child, see if any severe symptoms are coming, if it is in fact coming back, and if the second dose needs to be given is going to be what I ultimately would recommend. And so then that's going to be where, if you have those circumstances where you can go in the car to the emergency department, then that makes sense. But it also makes sense to be getting the information and the data in a safe place where then the ambulance ultimately would be able to get to you and would be able to be called if you need it. And so these are going to be excellent conversations to have with your clinician. And a lot of this is going to depend on also like where you live, how far away things are, you as a parent and how you feel about it, and them as a clinician and how they feel about it. Some of us are still getting used to this.
Yes, as we do. We just adapt and we take the new information in, and then it takes time to emotionally and mentally adjust to it, right?
Totally.
Well, thank you for helping us do that. This is going to be incredibly helpful for people. I appreciate it so much.
Well, thank you so much for having me.
What an empowering discussion. I hope that Dr. Pistner's language and his approach to thinking about this will be a relief for you to hear and to have in your heads, and to know that with the right information, tools, and practice, we really can be ready to respond calmly and effectively in an emergency. So here are 3 action steps to help you put what you learned today into practice. Number 1, again, follow Dr. Pistner's work. The website is massgeneral.org/children/allergy. You'll find so many resources and so much information there, as well as links to their social media. On Facebook, you can find the Food Allergy Center at MGH and an account for their Food Allergy Buddies program. Number 2, watch the video of proper epinephrine administration for infants and toddlers on my Instagram page at the Food Allergy Psychologist. Dr. Pistner will show you exactly what he's describing in this episode. And number 3, review your family's allergy action plan. Check that your epinephrine devices are up to date, your caregivers know where they're kept, how to use them, and everyone in your child's circle feels confident about when epinephrine is necessary. All the links to everything that we talked about in last week's episode and this one will be in the notes. So when you have a chance, please take the time to find the resources that you want to review more carefully. Thank you again so much to Dr. Pistner for taking so much time with me. The content of this podcast is for informational and educational purposes only and is not a substitute for professional medical or mental health advice, diagnosis, or treatment. If you have any questions about your own medical experience or mental health needs, please consult a professional. I'm Dr. Amanda Whitehouse. Thanks for joining me. And until we chat again, remember, don't feed fear.